Good evening. It's 6:05 p.m. My name is June Mutwiri. I'd like to welcome you to this evening session. Topic will be Beyond Blame, Medication Safety in Anesthesia Practice. Our speaker today is Dr. Anthony Gatheru, who's an anesthesiologist and a lecturer at the Department of Anesthesia, University of Nairobi. We will also be joined by a panelist. She's Dr. Clarice Ambale. A brief introduction to Dr. Clarice. She's a pharmacoepidemiologist and health system strengthening expert with over 17 years experience in hospital pharmacy practice and health system strengthening. She has worked in both public sector and non-governmental organizations. She has expertise in public health programs, particularly HIV and TB. She is passionate about patient safety. She holds a master's degree in pharmacoepidemiology and pharmacovigilance and a bachelor's degree in pharmacy from the University of Nairobi. She is currently pursuing a doctorate in tropical and infectious diseases at the University of Nairobi. She has interests in research and has been involved in several studies and published papers in peer-reviewed journals. She's a member of the Pharmacovigilance Expert Review Committee. She's an active member of the Hospital Pharmacists Association of Kenya, where she's currently serving as an elected national committee member. She's also a member of the Pharmaceutical Society of Kenya, International Society of Pharmacovigilance, and International Society of Pharmacoepidemiology. So welcome, Dr. Anthony Gatheru and Dr. Clarice. We can begin. Let's give Dr. Gatheru a minute or so to handle his mic.
Thank you. Thank you so much for this opportunity, ladies and gentlemen. I missed the introduction, but that is who I am. And we are going to spend about 30 to 40 minutes talking about a topic that has become a major subject of interest in our specialty. I am aware that the audience includes people outside our specialty, but this is basically tailored for the anesthesia provider. So I have no disclosures to make. Now, we are going to be talking about medication errors as far as medication safety is concerned. And by the WHO definition, a medication error is a preventable event that may cause or lead to inappropriate medication use or patient harm. While the medication is in the control of the healthcare professional, in the control of the patient themselves or the consumer. So a medication error can also occur when it's with the patient themselves or the consumer. It's quite costly, and it is thought that the harm that comes from Medicare, about half of it is from medication errors. Now, for us in anesthesia, we are at a particular risk of being in this situation of medication errors as in our daily practice. We know most of our work is in the operating room, which is a demanding and a time constraint setting. We have turnover demands from management. We have targets to meet. It's a high risk environment. So decisions have to be made rapidly. Sometimes decisions have to change. We are using highly potent drugs whose effects happen immediately with very narrow therapeutic windows. The anesthesia provider is a person who orders the medication, basically prescribes the medication, is the one who prepares and administers the medication and monitors the effect. That is one individual. In the other hospital setup, you probably have a clinician doing the prescription. We have the people from pharmacy doing the preparation and the interpretation of the prescription. We have the nurse doing the administration and the monitoring. And therefore, in the anesthesia situation, then there's an exponential rise in situations where we can have medication errors. They can cause rapid severe harm, and some of them, actually most of them, will basically pass unnoticed. However, they should be reported because from the seemingly innocuous errors to these ones that cause harm is where we change systems so that we can avoid them. Our medications have very narrow therapeutic windows, and they do not give us much room for wiggle when medication errors occur. So the epidemiology of medication errors worldwide is very difficult to report. It varies from all the sources I checked. The one from 1 in 450 medications to 1 in 103 for anesthetic cases. Now, these are from incidence reports. However, we have this thorny problem of underreporting. Now, when we have facilitated incident techniques being used to study, then you see we arrive at a rate of 1 out of 1 medication error in 133 anesthetics. However, even this is thought to be an underreporting. We are probably closer to 1 medication error for every 20 anesthetics done. And this is because, of course, of reporting bias. Our regions where we are in the low and middle income countries, it is postulated that we actually have higher severity and higher incidences of these medication errors. And we also have lower reporting rates depending on the different institutions. So why do we have this problem of underreporting? Sometimes, and this is what has been postulated, is that we tend to recall only those incidences that resulted in an adverse drug reaction or where the patient actually came to harm. What is considered a medication error is highly subjective. Some of what we actually pass off as accidents are actually medication errors. For example, if 2 drugs meet downstream, or if you are using an infusion line and the 2 drugs combine before they reach the patient, that would be considered a medication error. But perhaps because there's no harm to the patient, we don't consider it as such and it's not reported as such. And so we fail to recognize many errors. Sometimes when we underdose patients or overdose patients, but no harm comes to them, then we also don't consider those to be errors. And then, of course, the harmful errors that can happen, there's underreporting because of fear of repercussions for the ones where actual harm comes to the patient. So from most of the records of what the medication errors that have been reported, most have come from the anesthesia incident forms, and many hospitals do have incident forms. Pharmacy reports, like Dr. Clarice will share with us some of what they have. And when critical incident meetings are done, root cause analysis or mortality morbidity audits, then that's where some get reported. Of course, there's a fear of blame. Then some an error on Monday, and I want to report it and document it in the incidents report. And then my theater case prolongs, and I rush home. And then the next day, I have a full day. And then by the end of the week, I've not reported this error. And then you find some of the reporting techniques are considered cumbersome, and of course, they believe that there was no harm. Then we'll talk a bit more about the culture of blame that may be attributed. So when can errors occur? Well, these medication errors, they can occur when we are giving the drug, when we are prescribing the drug, when we are preparing the drug and the whatever else we require to give the medication to the patient. That is some of the places where, and then during the actual administration of the drug. So they can, this is not in sequence of how medication errors can occur, but they can occur at administration, called administration errors. It can be during the prescription. And this is why we are saying in anesthesia providers, as anesthesia providers, we are doing all this ourselves. And therefore, we have at a higher risk, we have a multiplier effect of having errors come our way. And then during the preparation of this medication, because we are the ones doing it. So normally, when a medication error occurs, it's not one single reason that can be attributed to it. Normally, if you look, there's a chain of events that contribute to these errors. And usually, from innocuous errors, we end up with life-threatening errors. So in trying to mitigate for these errors, we have to look at all those events in the chain and see how we can close those gaps. In all this, communication is key. We can have, when we have new medications come into our ORs, and for example, when we started using dexmedetomidine in Kenya about 6 years ago, there was a lot of misunderstanding about the dosing, whether it was micrograms per kilo, per hour, or per minute, and that may have led to medication errors. Inexperience, that is, you are new to a drug, you don't know how a system works, you are new to a system, or over experience, you have been in a system for so long that perhaps new management-driven protocols of mitigating medication errors are considered a nuisance to you. Then we have environmental factors, which should not be an excuse: fatigue and routine. Now, there's one that I want to talk about that is often overlooked. Sometimes in anesthesia, we have several routes through which drugs can be administered. You can have a patient who has an NG tube, who has an epidural catheter in situ, who has an arch line, and therefore you may end up, for example, having a drug that should have gone in the IV going to the epidural catheter, or vice versa. And this we should always have in the back of our minds, that which drug goes to what route. So we had alluded to that. So in that circle of the medication process, the anesthetist is center. Unlike in the other hospital setup where there are other key players, and the anesthetist has to take charge of all these processes to minimize medication errors. So during the medication process, we can have errors during ordering, that is during the prescription, so to speak. You want to put a patient under, you've decided you want to use sodium thiopental, so you want to know what dose you are going to give, at what rate are we going to give it, what is the route. Then during transcribing, sorry, I went ahead, we need to know what route we are giving, what dose, is this the correct patient? Are there any alerts on this patient, for example, allergies that you should worry about? And then we are the ones to dispense those medications, because in the we also act as pharmacists in the operating room, because we have the medication cabinet where we pick the drugs ourselves. So errors can occur at that point. And then during the administration of the drug, errors can occur. So multiple places. And if you look at the diagram on your right, I hope you can see my cursor. We have very many hotspots where we can have issues and problems arising from prescription. What is in blue basically is the processes of prescription and preparation of drug, dispensation, administration of drug, recording and monitoring. And then below there, where there are some other sub-steps, when you get these presentations, you'll be able to blow up the screen and see it. I couldn't get it any better. And therefore, when it is one individual doing all this, you can see there are 68 possible places where things could go wrong. Of course, this is not to make us stop doing our work as anesthetists, but it's just to highlight that every single day that we're in that operating room, we are, no matter how experienced we are, no matter how used to the system we are at a risk of medication error. Now, this is a typical operating room map. We have the patient here on the operating table. We have the anesthesia machine here. We have the surgeon as number 3. Now, typically, we have the anesthesia machine on what is labeled as R, which is the right side. And then we have the medications. Normally, most of us have our IVs on the left. Now, we have put processes to mitigate errors on the right side of the anesthetic workstation. On the right side, we have things that we cannot override. We have worked over the years, for over 45 years. We have the color coding, we have pin index systems, we have pressure flow sensors, we have the failure devices, all that. However, on the left side, we have not been as successful in putting measures to prevent errors. And therefore, from the origins of anesthesia, we used to have problems on the right side. Now they are moving to the left side. And now that is why we need a systematic approach to work on that. So we must have strategies to reduce medication errors, and we should focus on all possible causes. And these causes could be many. They are patient-dependent factors. Patient-dependent factors. Remember, we've had topics about how to deal with obesity, for example, when you need to know, am I going to use dry weight? Am I going to use, or during the dosing of medication, am I going to use dry weight or ideal body weight? We have organizational systems. We have a rule now that we are supposed to have turnover time of 10 minutes between patients. How do we look at this and how they can cause medication errors? There are human factors because we are all human. We have had our bad day in traffic when coming to work, so you're already angry. You are working with perhaps not your most popular surgeon, and do those dynamics play? So the anesthesiologist has to remember all this. There has to be center in all the steps to mitigate medication errors in the OR. And even where management comes in, the voice of the anesthesia provider has to be loud. And then our seniors must walk this walk with us so that we accept that we are also susceptible to errors, because normally it is the senior people in the profession who lead change. And I've just been having a talk with one of the theater managers in the theater I was in earlier today. And this was one of her concerns, that normally new systemic changes brought about to mitigate errors are mostly resisted by the people who have been at the job for long. Sorry, that's a generator coming to life. I hope it's not affecting my sound quality too much. June, am I audible?
You are
Yes,
okay.
you are.
Okay, thank you. And then information is king when we are talking about strategies to mitigate medication errors. We need information. Remember, we have said this overwhelming underreporting. So we have to collect data to know where we are and where we want to be. This should actually be target markers or towards eliminating these errors completely. So we need procedural safeguards. The same way we have said we have worked on the right side of the machine of the anesthetic workstation to minimize errors. We need procedural safeguards. For example, we need institutional-led protocols. For example, we may have the same way we do with blood products. We have 2 people checking every prescription and before administration. We need to minimize distractions in the operating room. For example, when your patient is on the table, we have seen this happening many times. Your patient is wheeled in, the surgeon is already, doing what they call the decontamination of the site. You have not even given your anesthetics. And perhaps we should even have some protected time for the anesthesia provider to do their thing. Minimal distractions. For example, the WHO checklist should wait for some of the preparations to be done. We should avoid premature preparations. In as much as we want to improve on turnover, we also cannot, for example, be preparing our meds for the 4 p.m. Surgery at 10 a.m. because now we are going to have issues of cold chain, we are going to have issues of loss of potency, contamination, and perhaps a change of patients. And therefore, you end up giving drugs prepared for a different patient. And then standardization is very important. In systems where they have managed to reduce medication errors, they have done some level of standardization, which a standardized way of drawing drugs, administering drugs, and drugs that must be diluted, a standardized way of dilutions. And these have been shown to work. Environmental factors need to be worked on. And the first one is, of course, the personnel. And staff needs to know that medication errors are here with us and they must be avoided. And therefore, they should give that anesthesia protected time. It should be guarded by all the staff in the operating room. Equipment that we are going to be using to handle medication should be in tip-top condition. And basically, medications that have been that medications that are not being used or have not been labeled, syringes that have contents that we are not sure about should be discarded. And I'll digress here and talk about an incident that I may have shared with one or two of you, where I walked into an operating theater to give an anesthetic to a 1-year child. And the team before had been doing a cesarean section and a spinal anesthesia, subarachnoid block. And they had left an open vial of fentanyl and hyperbaric bupivacaine on the anesthetic tray. And of course, in the confusion of coming late and trying to put the patient under, I ended up drawing bupivacaine because the bupivacaine was in a vial that resembled the trachurium that was in that hospital, and actually administered it to that patient. What I thought was 3 milligrams of atracurium, and I think that was a saving grace. The patient came to no harm, and that's why I can talk about it now. I did report to the management of that hospital about that error. I don't know whether they put in place systems to make sure that when one team leaves, all the medications are discarded. And these are some of the problems that may arise. Communication is key. Two-person communication. This has worked very well in the blood product sector, and it can work in all medication. It is time consuming. It may be considered that we are impeding on theater turnover, but the cost of medication errors should make any management team realize that an extra 10 minutes is probably worth putting in. We should avoid use of abbreviations. Abbreviations have been shown to lead to medication errors, especially non-standardized abbreviations. And this is one of the things that JCI is very keen on. Abbreviations like PCM for paracetamol could also mean very many things to different people. And use of generic names, for example, Tramol, have been confused for Tracrium, and medication errors have occurred. And the WHO checklist should have some of these things. Now, I talked about standardization. Now, it's very debatable about standardization of drug presentation and drug preparations, and the nature of institutions is that perhaps if within institutions they can standardize how drugs are presented, then we may be able to minimize some of our medication errors. For example, we can use standard drug concentration. In the same institution, we should not perhaps be having heparin, which is 500 units per cc, and in the same institution we have one which is 5,000 international units per cc. That's what we are talking about, having standard concentrations in the institution. If we decide, for example, we are going to be using cisatracurium, we should have perhaps the same concentration. If we decide we are using morphine, because in the market we've been having a 30 milligram vial and a 10 milligram, that is a hot sort of medication error. Packaging is important. It's a whole topic. I know Dr. Clarice will talk about it. It's a thorn in our flesh. It has caused a lot of untold misery. And then we should have consistent storage system. And I'll show a photo again of some of the ORs that we have worked in, where, for example, vasopressors are kept in this drawer, the sedatives are kept here, local anesthetics are kept in a different compartment. Those are things that help us. Clear labeling, and ideally using standardized labels and color-coded labels for all medications, including the strengths. Color coding has worked for very many places, and color coding does not have to be the vial. It could be stickers. For example, institution can agree that all our vasoactive agents will have a sticker that is red. All the opioids will have a pink sticker. All the IV induction agents will have a green sticker, and that has helped. And then if we can separate hazardous medication, that would be great. And of course, we all know about the story of bupivacaine and tranexamic acid. So the Zeta environment is key. We should have sterile cockpits where we have a moment where we are able to focus on what drugs we need for our patient without distractions. I am not going to belabor the shorter working hour shifts because I know this one will draw a lot of issues, like, for example, what exactly is short? Is it individual dependent? For example, people who are in full-time private practice. What about institutional targets? But people should take breaks in between cases. For example, working 12 hours continuously, there's gradual deterioration of alertness as the day progresses. Having a case added to your list that was to end at 4 p.m. that will end at 8 p.m., that is a hot cake for medication errors. So these are just some of the ORs that I have been to between yesterday and today. And you can see how the drugs are brought to the anesthetist by the anesthesia technician before the start of the operation. And of course, we can see some good things. First of all, they are all neatly put. Now, the one on the left, they are not in any particular order. In that basket, you can see there are two local anesthetics. There is bupivacaine, there is lignocaine. In the same basket, you may not see, but there's adrenaline. There's tranexamic acid there. There is propofol at that corner, and then there's an antibiotic. Now, this is basically default to that, or it's brought to every anesthetist at the start of the case, and then you change it according to your preference. In the other one, this is a cabinet where the frequently used medications are put. They are arranged in an order. They are labeled. So you can see the reversal agents are in one corner. We have some opioids, some local anesthetics here, including bupivacaine, some paracetamol and antibiotics. Now, this is a bit harder to cause an error in the moments of lapses in the second case, but this could also be improved. You must agree. For example, I feel like some of the local anesthetics should be perhaps in a totally different drawer, but that's not the subject of today. Now, technology, equipment, and automation can also help us in minimizing medication errors. And I mentioned this because this is not common, but it's something to think about, is that perhaps we should have different connectors for the different routes. For example, the epidural catheter perhaps should have a different, not the standard connection, so that it should have different syringes that you can go in there, so that it's like what they do in the petrol stations. It would be very hard to put diesel in a petrol car because they have a kind of a pin index system, so that the nozzle for petrol will not fit in the tank of the diesel vehicle and vice versa. And we should perhaps adopt some of that in anesthesia. Barcode scanning has been used with success, especially out there in the West, where patients' details are put in, and the barcode scanner will give you, this is the name of the patient, this is the drug, should be given at this time, at this rate, and even if somebody else was to come, they'll be able to identify that is, even if you're having a second person, they can verify from that. Smart pumps, we haven't used them a lot because they are considered to be expensive, but they have to be properly programmed. It's not no use having a smart pump which is not well programmed. So if this have all the drug libraries, for example, of the different pressors, you put your concentration, the details of the patient, then it will give you some lockouts so that you're not underdosing, you're not overdosing, you're not giving boluses when you shouldn't, and they do exist. Now, I am going to spend some time to talk about prefilled syringes because they have come to our shores. They help us a lot in some of the medication errors that we are seeing about. And I think finance departments need to support us in the use of prefilled syringes. Initially, the push for prefilled syringes was from the sellers. And when I talked to one of the theater managers again in a hospital where they were using prefilled syringes, then after some time they disappeared. The fight, of course, was with finance because, for example, a prefilled syringe of atropine would probably be about 60 shillings, whereas the vial would be about 1 shilling. So when you do the multiplier effect, it's very hard to justify why it's the same drug. Why are we spending, 1,000 times more? But if you look at what I had shared before, prefilled syringes totally eliminates all the risks and are prepare. If you blow up this, the prefilled syringes has 19 failure modes have been eliminated by one intervention alone. So they are becoming cheaper. There are different people bringing them, and I think really we should fight for them. So let's talk about lookalikes because this is another problem. It's not the only problem, and this is not a talk about lookalikes. These are some of the lookalikes that we are seeing. Usually, for devices to be so identical, they're probably being manufactured by the same company. And of course, it's the same way like bottling companies. For example, those of you who ingest alcohol, if you take your Balozi today and that bottle goes back to the industry, tomorrow it will probably come back with Tusker because it's just going to be washed and they put a new label. So it saves a lot of money to the companies to have, vials that kind of resemble. They don't have to have different manufacturing plants for them. But of course, this is a problem for us as prescribers and dispensers. So you can see, for example, if you are to give somebody heparin in place of midazolam, that would be catastrophic. If you are trying to sort out nausea in your patient and you end up giving them phenylephrine, and now I haven't seen liposomal bupivacaine, but this I got from the internet. So we were very safe with propofol because we knew nothing looks like it. But now, if this is what liposomal bupivacaine looks like, I pray nobody gets to induce a patient with bupivacaine. And I think this is totally unacceptable. And then, of course, we have pancuronium and suxamethonium. This one, I'm sure you've seen it. The reason I've put this vial here is because it has a lookalike by the same company, a fentanyl vial. And I'm putting this because on Tuesday, I happened to anesthetize a mother to a colleague, and I gave the disclosure for this. And I was again in a theater where the anesthetic technician brings some premeditated medication for every anesthetic. And because I think the person who works there frequently probably uses pethidine, so pethidine was put in my trolley. But remember, this company has a fentanyl that resembles pethidine. And in my mind, I knew I was giving fentanyl, but this is what I ended up giving. So this is actually a photo that I took. And I only discovered this later when now we were doing the audit with the AA. And I'm asking, so we were looking at the vials because we had not discarded them. And I was asking, so how come I can see fentanyl here? And so that is what happened. So these are others that we have shared in our WhatsApp group, the KSA WhatsApp group. And these are in our shows. The first one I've put there, morphine and neostigmine. I actually intercepted a friend, a colleague. I just walked into their theater and were about to do a reversal from anesthesia, and were preparing the reversal agents, the neostigmine and glycopyrronium. And And then because I had seen the problem, and they were actually going to use morphine for the reversal. And probably it would have been the nuisance of staying longer in the OR, probably not fatal because it was an adult, and this is 10 milligrams. But you can see where I'm going with this. But now here we have dexamethasone and atropine. So you want to sort out your patient with perhaps some anaphylaxis, or you want to put it in your block and you end up giving atropine, or during reversal and you end up giving dexamethasone instead of atropine. And the examples are many. Of course, the most catastrophic is this one down here of bupivacaine and water for injection. And when I asked around, apparently this was a push from hospitals. It was actually not from pharma, where hospitals had approached a company, and the same company that makes a bupivacaine that looks like this. And the question was, how can you make the drug cheaper for us? And that was the solution from the pharma, to have a plastic vial. And now the elephant in the room, bupivacaine. I know we'll talk about a bit more about this. Bupivacaine lookalikes. This has caused that untold misery. Bupivacaine and tranexamic acid. We have very many reports, undocumented, of course, and published, of people getting tranexamic acid instead of bupivacaine for spinals, most of them women, for CS, and many of them ending up dead, many of them coming up to the referral hospitals being managed for different things. And it's not a new problem. The Bible says there's nothing new under the sun in Ecclesiastes. So if this happens to you, don't you worry. It is important to admit that this has happened so that we have a solution. This was published in the Anaesthesia Journal in 2019, and they had done an audit of catastrophic errors involving tranexamic acid. And in this, they had audited, basically they had 21 people who had gotten tranexamic acid intrathecally. And of these 21, 20 were actually supposed to be getting bupivacaine, hyperbaric bupivacaine. So the lookalike problem is not in Kenya alone, and it has not started today. And so we are not going to run away from it. And of those, 10 patients died. So this mortality rate is very high. And the remaining ones had significant harm. Actually, it was the only one who had no significant harm. And the one that was not tranexamic acid, this one basically had a spinal catheter and sorry, and it was mistaken for an intravenous catheter. So once we have these medication errors, we need to have proper documentation, proper audit. Dr. Clarice will tell us what the Pharmacy and Poisons Board have come up with. And then we have a system where we can analyze them, conduct regular audits, so that we learn from mistakes, monitor progress, whether we are improving, and avoid things in future. And then, of course, we should have feedback to the people who are involved, including the patient. I'll not belabor that. And now, when we talk about medication errors, there's somebody who is often forgotten. So we worry about the victim that's the first victim. We take care of the victim. We do disclosure for the victim. But what about the second victim, the person who perhaps is the one who, if it's not a systematic problem, if there's an individual who is supposed to have brought harm to this patient? So that first. So they do suffer feelings of guilt, loss of self-esteem. They have depression, of course. They wonder whether they are up to the task. They do have their professional abilities being questioned. Many times there's loss of income and job, because especially when these cases go to litigation, the first thing, and we shall talk about that later, the first thing that the organizations do is dismiss those individuals. So we have to worry about the second victim, because as long as the second victim suffers all this, then reporting will remain underwhelming. And then we have to discuss the adverse outcome with the patient or the patient's family. And this discussion is best done by the person, by the administrator of that medication. And then, of course, the second victim is under peer audit. And normally when the audit is done by peers, perhaps it's kinder than when it is done by the legal system. And so the American Society of Anesthesiologists came up with a statement on peer support because this was seen to be, people were focusing so much on the victim. And you'll find it in that link there. So there are some coping strategies which are encouraged and which may happen after after you cause a medication error. And some of those coping strategies, you may find somebody now has heightened attention to detail. They seek early assistance. They do the second checking and the cross checking. And so those are some of the people who you may hear people saying that they are very anal or they are very disruptive to first administration of anesthesia, and they are probably second victims. And then, of course, there can be the maladaptive coping strategy, where now the person becomes overly defensive. They will be ordering all sorts of tests. They'll be rejecting all sorts of medication. They will say they can only use products from a certain company. And of course, these have also probably been second victims. Now, when a person is a second victim, it is only fair that we get them off the workspace for a while. And this should not be in a punitive manner. It should not be that we rush and strike them off the call rota or off the admission, the admitting consultants of that hospital, because that is punitive. It's just to relieve them off duty to debrief, same thing that we do if we have a death on our operating tables. And this is very therapeutic. And then, of course, peer support, talk to them, and people are opening up about these things. And therefore, they'll find people to talk to when they have shared. And as I told you, my experience of of bupivacaine IV in a child, 1 year old, I had to talk to 2 or 3 peers. Of course, there were people I trusted. I didn't want this going out there, but I've now spoken to a wider audience to see that some of those advice that are left by your peers, by the people, the team ahead of you, can land you in problems. And then we have the unfortunate knee-jerk reaction of criminalization of medical errors. And we have, for example, as a society, to advocate that medical errors should not be criminalized. Whatever we do, we should not criminalize medical errors. We have to talk to the masses during the anesthesia the day, the word anesthesia day. We have to do mass education. We have to involve the media. When we talk to the patients at individual levels, patients have to be told. If a patient comes and tells you, there was a doctor who was negligent to me and they gave me a drug that I got a reaction to, the word negligent is being thrown around too casually. Medication error is not equivalent to negligence. If I give you a drug that you get an allergic reaction to, that is not negligence. So we need to also, every time we do our pre-op to the patient, talk to them, educate them, so that we have, if you look at the way, for example, aviation accidents are approached, it's totally different from how medical errors are approached. Medical errors are approached the same way matatu accidents are approached. Careless doctor, careless matatu driver, that is the wording even in the press. So we have this unfortunate case that happened, and I'm sharing it here because it was all over the news and all over the media, and there was a lot of involvement from politicians, where a baby, 7-year-old with 7 months, went to a hospital, had suffered burns, and the doctor who saw this child prescribed morphine because the child was in a lot of pain. And superficial burns can be very painful. However, during the prescription, and this is hearsay, I don't have the facts, but this case has actually been to court, and I even saw, I think, from the judiciary. It's in the Judicial Gazette, so I can talk about it. So the doctor wanted to give this child 1 milligram of morphine, presumably IM, intramuscular. Presumably the child was probably about 7 kilos or 10 kilos. So 1 milligram makes sense. Unfortunately, they wrote 1 ml of morphine. The person dispensing the medication dispensed it. There was a failure at that point because you should not dispense a medication like that prescribed as a ml. And then the person injected 1 ml of morphine to this 7-month-old baby. And of course, the baby ended up losing its life. But the problem was a backlash. Including the governor of that county at that point. He got a lot of political mileage from this. We have this other that I saw in the press, family seeks justice as kin dies after killer injection at health center in Kakamega. I don't know the details of this case in a health center, but from the article, and the link is there, you can read it. These are some of the statements from that article. He then injected her with some drug and she began feeling nauseated. The doctor called his colleague and they began administering first aid, but she unfortunately did not make it. The autopsy report revealed that the deceased died of therapeutic misadventure, a condition caused by adverse medical management. We are fighting for our rights. Why did our sister die? She walked into the hospital by herself together with her kid, but she did not return. Now, and the most heartbreaking statement, the medic responsible allegedly vanished after efforts to resuscitate the patient died, leaving the family devastated. So you can imagine what the situation at that point. And this medic, probably there was so much hostility. That was the only way he was going to save his life. So the ASA has also come up with a statement about criminalization of medical errors. And I think as KSA, we should also come up with a statement about criminalization of medical errors. And I think this one should be interrogated by peers and not by the police, for example. Because when we end up criminalizing, what happens? We don't errors are not reported, so they keep being happening to other people. And that is what is happening to tranexamic acid. It keeps happening. It has been talked about, it's been published, but it keeps happening up to date. Now, patient safety initiatives are undermined. Then we focus on blame rather than sorting out the systemic issues. We focus on an individual. So the individual, we get them out of the system. It happens to another individual tomorrow. We have not solved any problem. And many times, this person is probably innocent. For example, the person who was administering one meal as ordered was basically doing their job how they have been taught to. Okay, but they also ended up being dragged into the cells. So we can have alternative solutions. Let's look at systems. Let's promote open reporting let our root cause analysis not be so hostile. Okay, and then perhaps because at the end of the day, we have to worry about the first victim, the patient. We are not going to say that we are going to absolve or not take responsibility. But instead of criminal proceedings, errors can be addressed through other means. They can be civil matters, perhaps license suspension, for example, for repeat people who have been caught in this situation many times, being encouraged to seek perhaps alternative careers, rather than criminalizing it. So we have to balance no blame with accountability. We cannot say now we don't want to criminalize medical errors and at the same time keep having them. So we have to balance this, but that is not for me to dissect today. Thank you so much, good people. I beg to stop here.
Thank you very much, Dr. Gaveru. We now invite Dr. Clarice, and then we'll get into the Q&A session later.
Good evening. Justin, please confirm you can see my screen and hear me.
Yes, we can.
Okay, thank you so much for joining this CME, and thank you to KSA for inviting me. I'm here courtesy of PERAC. PERAC is the Pharmacovigilance Expert Review and Advisory Committee at the Pharmacy and Poisons Board. And it's responsible for analyzing reports that are received by the National Pharmacovigilance Sorry, my network dropped. Let me just share my screen again. Kindly confirm you can hear me now.
Yes, you're audible.
Okay. So mentioning that I'm here courtesy of PERAC, Poisons Board, and Poisons Board, health products and technology in the country, and they're responsible for ensuring that all the medicines, devices, diagnostics that are used in the country are safe and do not cause harm. I serve as a member of that committee that analyzes and assesses the causality of adverse drug reactions reported. Just to give you a background of pharmacovigilance, this is a science and it involves activity related to detecting, assessing, understanding, preventing, and even managing of the effects of any other drug-related problems. And as Dr. Gaberu has correctly put it and expounded upon it so much, anesthesiologists and anesthetists work in a very high-risk, high-pressure environment, and their concerns due to the use of high-risk medications that are used in the theater. You administer medicines rapidly, you use multiple medicines, and there's limited time for cross-checking, and hence the probability of these errors occurring in the theater is very high. And some of these adverse reactions that have been reported include hypertension, anaphylaxis, we have medication errors, and also drug interactions. And these risk factors, as mentioned, are due to the multiple routes that are used in the theater, narrow therapeutic windows of most of the theater drugs, rapid onset and offset of action, and also limited patient communication in the theater. Some of them are already unconscious or sedated. So we analyzed reports that were related to theater drugs between January 2021 to September 2025. And there were about 5,188 total number of ADRs reported in that period, but only 71 reports were on theater medication. And the reported medications were 71, and you can see the reports for bupivacaine were the highest at 18. Also, lignocaine reports were at 18, followed by morphine and tramadol. The rest were 1 reports each. So we have data on the counties that are making these reports. This is specifically for the theater drugs, not the total number of ADR. For theater drugs, Nairobi County is reporting the most at 14 reports, followed by Mombasa, Kakamega, and Kirinyaga, and the rest, as you can see on the screen. And who are the cadres making these reports to the regulator? Nurses reported areas involving theater drugs. We had OBS-GYN, 4 of them, pharmaceutical technology, 17, and the majority of the reports are done by pharmacists. As you can see, there are no anesthesiologists, no anesthetists, as much as we encounter these issues in the theater where we work. Of interest is bupivacaine-related adverse drug reactions. And we had quite a number between January 2021 to September 30th this year. We had 21 reports involving bupivacaine. We call them suspected until the causality is done and a causality assigned to bupivacaine. So we had 21 reports, and out of the 21, 20 were initial reports, 1 was a follow-up report. So the suspected medicine in all these 21 reports was bupivacaine in different forms and in combination with other medications. So the commonly reported adverse drug reactions from the 21 reports on bupivacaine were as indicated. The majority were on convulsion, confusion, and pruritus. Convulsion was the most reported ADR. Unfortunately, a good number ended in fatalities, that is 7, some of them including both the mother and the unborn baby. And remember, Dr. Gaveru gave us some basic, cheap, no-cost solution that can be instituted to prevent medication errors, which can avoid loss of lives, as we have seen in the previous reports. So the Pharmacy and Poisons Board has taken action to try and address these minutes regarding ADS, and in particular with the bupivacaine. The cases that were tabled before PERAC and recommendations were issued as below. Quality analysis in the quality control labs of suspected poor quality product. It's not enough to say bupivacaine caused this, bupivacaine was of poor quality. Was the quality assessed and determined that the causality was of course due to bupivacaine? They also issued a safety alert from the Pharmacy and Poisons Board. It's on the website. The Pharmacy and Poisons Board also released a notice to market authorization holders. We call them AMAH. Because not all the drugs are manufactured in Kenya, but they have MAHs based in Kenya who now represent the manufacturers. So they were given a notice to address lookalike medications, which you've seen a number of in Dr. Gaveru's presentation. And they are required to provide a plan to the board by the 31st of December on how they're going to change packaging to avoid confusion between the drugs that look alike, especially if they're from the same company and they're packaging them the same way, labeling them the same way, the same font, the same color. And so it's very easy for someone to confuse, as we've seen in the case of tranexamic and bupivacaine. And we know there are cases that have happened where tranexamic has been administered and postmortem results have shown it was found in the CSF. We also held a roundtable discussion with stakeholders of the board on the 27th of June, just to discuss the issues around bupivacaine in particular, and generally medication errors and adverse drug reactions occurring due to theater medication. These stakeholders included representatives from ASA, representatives from NACOA. NACOA is Nurse Anesthetists and Clinical Officer Anesthetic Association, the board, representatives, PERAC, and also pharmacists from various hospitals. Another action that was recommended was GMP inspection of bupivacaine manufacturing site, which is scheduled to happen soon. So these are some of the recommendations from the roundtable discussion on bupivacaine. Associations to plan and implement training for their members on safe and effective use of anesthesia, health products, and technologies, particularly the administration of bupivacaine. Building capacity on pharmacovigilance of health products and technologies through the multiple available platforms, including pharmacovigilance, electronic reporting system, and mobile application. And we'll go through the reporting system at the end of these slides. Training members on effective response to adverse drug reactions, related emergencies to prevent adverse outcomes. Sometimes these emergencies happen, but what do we do after they happen? Do we manage the patients adequately to avoid loss of life? Our members' capacity built enough to manage these reactions when they occur, if they do occur at all. So some of the theater-related medication errors that have been reported, we had a total of 50 medication errors reported to the National Pharmacovigilance Center that involved theater medication. And a good number involved morphine at 48. Bupivacaine, only one medication error has been reported. Remember the rest, the 20 that I mentioned in the previous slide were just adverse drug reactions, and they were suspecting poor quality bupivacaine. But medication errors, only one have been reported on bupivacaine and another one on lignocaine. And the type of errors that were reported were affecting the prescribing and administration stages of medication use. So just a reminder that you do not need to be certain that it's a medication. If you suspect you've made an error, or you know you've made an error, just report all suspected either to the Pharmacy and Poisons Board. And so how do we report these events? Because they do happen for sure. Adverse drug reactions, medication errors, and any other drug-related problems that we encounter in our places of work. How do we report this? So I'm going to share with you 2 slides, and then we'll go to the portal where we can do the reporting. So a second, I share the other screen. Okay, Justin, please confirm you can see my other screen.
Yes, we can.
Okay. So when you log into this URL, when you click on the URL, it will take you to this page. And on this page, if you have an account with the Pharmacy and Poisons Board, you will log in and do the report. There are various forms. We not only report medication errors, we do report suspected adverse drug reaction. We report suspected poor quality medication, transfusion reactions, adverse events following immunization, and errors due to medical quality issues due to medical devices. So if you have an account, you do log in. If you don't, then you register. So we'll go to that portal and see how you register. We also have mobile applications. If you go to your Google Play Store or Apple Store, if you are using an iOS device, then you search for MPVAS, you will find it. Initially, it will bring you MOVAS, but keep searching for MPVAS. Then you install it and you can report from wherever you are. You don't have to log into the portal to do the report. You can use the mobile application to do the report. So there shouldn't be any hindrances to us doing the reports because of time constraints, or we don't have the tools. The tools are available with us wherever we are with our smartphones. We also have a USSD code that can be used for reporting, mostly by the public. You've had Dr. Gaderu share experiences from patient relatives or patients themselves on how they experienced medication-related issues. So we need to empower our patients. In case they experience this, they can dial the USSD code *271# and report. This report is very basic. It doesn't ask the patient for many details about the medication, which they might not have. But if it's a healthcare worker, then they need to use the reporting systems, platforms, the MPVAS app, or the portal to do the reports. So we'll quickly look at how to do the reports from the portal. So I'll now share my screen again, and we go through how to register and do the report. Just a minute. So as we continue, let me ask if any one of us has ever reported any issue with a drug. As I share my screen, just type in the chat if you ever reported any issue with a drug yourself, or you've shared with a pharmacy. I know some of us just share with pharmacists and tell them this drug has an issue or a patient experienced this, and then we ask them to do the report for us. So how many of us have ever done the reports? Justin, you can monitor the chat. So when you click on that URL, which I think I'll put in the chat as we continue with the Q&A, it will take you to this page. And then you can log in or you can register. So if you have an account, then you will log in with your credentials. If you don't have an account, then you will register. The information required is very basic, which you have with you. You don't need very complicated or detailed information for you to register. You key in your preferred username, your preferred password, you confirm it, then your full name, your email address, your number, and your designation. You don't need to click here because these are for the manufacturer, and those who are reporting on behalf of the manufacturer or distributor. For institution, you put in your institution. Some of these codes are not necessary. Some of the fields are not mandatory. So if you don't have any of these information, you don't need to type it in, but at least you need to put your institution of where you're reporting from. Some of us probably are freelance or not working in a particular institution, work in many. So if the field is not mandatory and you don't have the information, you really don't need to fill it. It's just as simple as that. It will take you like 3 minutes and you're registered. So if you finish filling the information, you submit, and now you can log in and do your report. So I think that password is incorrect. So when you log in and do your report, it will take you to that page that I initially showed you. General public members can also submit a report. They don't need to register. They just go to the portal and click submit a report. And they key in the information, the person reporting. They can even put in the initials, the county, the email address, and then the details of the patient. They don't have to put in full details, and they describe the effects. If they're reporting a side effect or they're reporting a poor quality medication. The general public can also report poor quality medication in case they bought a medicine or they are given in a hospital and probably it's molding or it's caked or it has issue, the syrup is not does not have consistent viscosity. There are many minor issues with our medication that can affect use by our patient. So they can also come and report as the public. So the reporting system is as simple as that. We have no reason for not reporting. It's not complicated. We cannot say it takes a lot of time. We cannot say there are no cases to report because the cases are there. And remember, these cases don't just end up at Pharmacy and Poisons Board. They are submitted to the Uppsala Monitoring Center through a system called Visualize, and they end up in a system called VGBase, which collects information from across the world. And this information is used to generate signals, and signals inform decisions on drugs, whether to change the indication, to change the dose, to change the population in which it's used, and many other, or even to withdraw the drugs from use. So please let us report. It will inform policy, it will inform the decision to send a notice to manufacturers to address the look-alike packaging because of the reports that have been received about confusion that has been brought about by packages that look alike. So I encourage us as users of these medicines that have a high potential to cause ADRs to please do the reports. You have seen from the cadre that are reporting, we don't have any anesthesiologists, no anesthetists doing the reports. And you are the users of this medication. We probably witness the ADRs firsthand. We probably encounter medication errors firsthand. And as Dr. Gavero has explained clearly, medication error reporting is not meant to be punitive. It's meant to address the root causes that led to the errors to prevent it from happening again and causing harm and loss of life for our patient. So I encourage us to register on the portal and continue reporting so that this body of evidence can be used to inform decision making. Thank you very much, and back to you, Justine.
Thank you very much, Clarice, for demonstrating how we can report these errors and also informing us about our statistics. We go to the chat box. This question to you, Dr. Clarice, where Dr. Lee asks, must someone register to report a medical error? And would that be a hindrance, especially if promoting a no-blame culture? Over to you, Clarice.
Justin? Is that a
Dr.
question for
Clarice,
me?
can you hear? Yes, it was a question for you.
Can you come again, kindly?
So, someone asks, must someone register to report a medical error? And won't that be a hindrance, especially if promoting a no-blame culture? Dr. Clarice, can you hear me?
Sorry, I'm struggling to hear.
Okay.
Yeah, just
you-
come again, can hear you. Come
You
again,
can hear
kindly.
me? Okay, so the questions are, must someone register to report a medical error? And won't that be a hindrance, especially if promoting a no-blame culture? Another question that has been asked is, do our hospital reporting forms reach your offices?
Okay, so let me start with the first one. I hope you can hear me. Please confirm.
Yes, yes.
Yeah, so you register on the portal to do any reports. You don't register to do medication error reports. Yeah, when you go to the portal, because of time, I didn't go through the tools. They have different colors. So we have the yellow form for suspected adverse drug reactions. We have the pink form for poor quality medicine, the white form for adverse events following immunization, the off-white form for transfusion-related reaction, the blue form for reporting medication errors, and the green form for reporting issues related to medical devices. So when you register on the portal, you're not registering to report medication errors. You're just registering to report any issue related to pharmacovigilance, which could be in any of those 6 that I've listed. And when you do report, you might even not say you are the one who did the error. By the way, you don't have to mention your name, but because you have registered as yourself to do the report, then it will show you are the one reporting, but you don't have to say you are the one who did the error. You don't have to. The essence of reporting is to just show the propensity of errors occurring, the frequency of some errors occurring in some situations and with some particular medication, so that measures can be put in place to prevent them from happening again. It is not to look for you, the report, and say, okay, Dr. So-and-so, you did this, now we are coming for you. No, that is not the essence of reporting medication errors. The essence of reporting medication error is to address the root cause and not to look for the offender and punish them. So let's not fear reporting medication errors. Some hospitals have systems, like I know KMH, they have a book where healthcare workers go and report. And you don't have to say your name. You just say this and this happened in this department with this drug. Did it end up, was it a near miss? A near miss is an error that never reaches the patient. But you see, if it's not addressed next time, it can reach the patient. So you say if it's a near miss or it actually reached the patient. And Kelvin is asking if the forms reach the offices. As I mentioned, the systems are digitalized. Of course, the hard copy forms are still available, but with all this technology available, why do we need to fill hard copy forms? You can use the application on your mobile phones. You can go to the portal. I've shared the link and register and report them. We really are avoiding using papers, and we are going paperless. Yeah, I see Stephen Okello saying there should be an option of reporting anonymously. Yes, I think that can be taken up with the board so that we can report anonymously. But hospitals can actually do that. As I mentioned, KNH has that system where healthcare workers can just go and fill in the book of errors that either occurred or almost occurred. Then someone realized and, they did the right thing. But what if it occurs again? Because the situations that made it to occur are still there. If you don't report, then they will not be addressed. So I think the issue of reporting anonymously can be addressed by the board. That's noted. I don't know if there are any other questions. Okay, Nancy is saying the process should be made very simple, and I hope some officers from the board have joined and they're taking note of the comments that need to be addressed by the board. So just in case they are not here, kindly you can share with us these comments so that they can be given feedback on what to address. Yeah, Brenda is saying the online reporting form is quite long. Can this be looked into? Please make it as simple as writing a product review. Thank you, Brenda. Yeah, so most of those fields are actually important because we need to know what were the medication in question. What were other concomitant medication, especially if it's an ADR? Yeah, you could be assuming it's bupivacaine, but there were other concomitant medications that could also be causing the same adverse drug reaction. So you need all that. You also need the history of the patient, what were they being treated for. For poor quality medicine, you will need the batch number, the brand name of the product. Because here you're dealing with a specific brand that had a quality issue. So most of those fields are actually necessary. Yeah, and you're saying registering and opening an account is a hindrance. All right, so those sentiments are quite valid and they are noted, and the board will be given feedback. Stephen Okello is saying we need to strengthen prevention in addition to relying on reporting. Yes, so patient education is important, and the board has been doing quite a lot of publicity on social media, encouraging patients to, avoid self-medication, for example, and report any issues with medication, rational drug use. And it's also our role as healthcare workers to educate our patients on the right use of medication and to report in case they notice any untoward effects of the drug they're using. Not just you assume, okay, I'm feeling this because the drug is now working. By the time they come to us, it's serious and it can cause harm, increase hospitalization, need more treatment, and unfortunately some of these errors, some of these reactions do cause death. Okay, Justin, I think I can stop here. I see comments are still checking in. Before I saying when the board licenses drug, do they check like the look-alike drugs? Yes, they do. The companies actually present the packaging for approval, but then it's only they present the packaging for, let's say, tranexamic today, and it's approved, and then next month they present for the bupivacaine. I don't think the board, and this is my personal opinion, I'm not speaking about the board at this point, is able to compare, okay, manufacturer so brought in this, so let's compare with what they brought in today to see if they look alike. These problems are noticed by the users. That's why we need to report so that the manufacturers to change the packaging. But packaging is actually approved by the board. Okay, you mentioned there's a gap there. I think the board members, officers are taking notes and they'll give feedback to their bosses. Justin, back to you. Thank you.
Thank you very much. We also like to thank our participants for listening in. Anyone else with a pressing comment, question, or someone who would like to engage us? I can see one hand up. Linda?
Thank you very much for the great presentations, Dr. Gatheru and Dr. Clarice. Okay, mine is a bit maybe off, but the topic, but I'd like to address this question to Dr. Clarice and maybe to give us some guidance on this. In the counties, sometimes when drugs are procured, we have like the drugs which have a very short expiry and are the only ones that are available. When they're supplied to us and we raise the concerns with the pharmacy, and we say, okay, the expiry date is a bit, it's too close to the date. And then they will tell us you can actually use, like, let's say the drug was expiring on, let's say, 20th of October. They said you can continue using the drugs up to even 31st of October, and it is still okay. Dr. Clarice, could you, what is the view of the pharmacists on this, or on the board on this? Is it that the date of expiry, or the way we are told we can extend by a few days, and sometimes that's the only thing that is available? Could you kindly guide us on this? And also to my colleagues, maybe with your experiences, what you could contribute to, especially with our anesthesia medication. Thank you.
Okay, thank you so much, Linda, for your question. The expiry date is put on the drug for a reason. And if anyone uses a drug beyond that expiry date, then if they experience any consequences, they have themselves to blame. After the expiry date, the drug starts losing potency. So you cannot assume if a drug is expiring on 31st of October, on 1st of October, it's still as potent as it was. Of course, it will maintain some potency. So if you use it even 1 month later, it might work. But the potency is not at 100%. And because of the excipients that are there in the drug and the loss of potency, the patient might experience some adverse reactions. And if you're the one administering it, then you are liable. You are responsible for those reactions. So I'd urge us to just stick to the expiry date as indicated by the manufacturer and discard the drugs and use drugs that are not yet expired. Otherwise, we'll be responsible for any consequences occurring due to use of expired products, because potency will have gone down and other things can occur due to use of expired commodities. And the manufacturer will not, even if you report, the manufacturer will not be responsible for such reactions. Yeah. Over.
Thank you.
Stephen Okello?
Thank you very much to the organizers, and thank you, Dr. Gaveru and Clarice. I just have some comments to make. Some of them already posted. To the PPB, I think for anesthesia drugs, it's a special challenge. It's not like talking about antibiotics and stuff like that, because the mistakes, the patient will not even have the time or chance to report the complications to you. So I think we need to engage a little more closely, and I think KSA is more than willing to assist with that from previous discussions. And I already mentioned that you need to allow people to report anonymously. I can assure you no anesthetist is going to report through that form that you've put online for fear of victimization and criminalization that Gaveru aptly discussed earlier in the presentation. So if you really need this information out, allow us to do it anonymously. There's a lot of fears. We know how powerful the farmers are. We don't want anesthetists being called in the dead of the night with threats from over here because you're the one who doesn't want to use my drug, or you're saying my drug is killing people. So I think PPB, you need to take a proactive step towards preventing, and I'm talking about anesthetics, not the drug over-the-counter drugs, the drug that we use. If you do that, from what Dr. Gadwe already mentioned, starting all the way from the identification of the lookalikes, you should not throw that responsibility to us. Our responsibility will be to confirm that we are giving the drugs, but some of those colors and prints and fonts and everything are either so close to one another or so tiny that you actually need magnifying glasses to read them. So all these things, I think, fall squarely on the PPB, and I think we should be able to engage with you much more later to see how this can be prevented. Otherwise, we're still going to have these things and it's costing us lives unnecessarily. Thank you very much. And we are looking forward to working with you closely and protecting our patients.
Thank you very much. I believe Clarice is also actively answering your questions on the chat box. Anyone else with a pressing matter? Okay. With that, we can come to a close of the meeting. Thank you very much, Dr. Clarice and Dr. Gatheru. They were wonderful presentations, and have a good evening.